Over the course of a single year, the world has changed in ways that few could have imagined. But some did warn of the risks of a pandemic, and we're all still wrestling with how to cope with coronavirus. So are we repeating now some of the mistakes we made at the start? This is COVID Crisis, Learning the Lessons. Good evening, I'm Sophy Ridge. Over the next hour, we'll be examining the strategies used to try and defeat the virus while protecting the NHS and the economy based on the most comprehensive timeline yet assembled of the UK's response. And we'll ask whether we're making better decisions as we grapple with the second wave of COVID-19. With us tonight, the former Health Secretary and current chair of the Health Select Committee, Jeremy Hunt, plus the chair of the NHS Confederation, Lord Victor Adebowale. Joining them as we analyse the key moments, the big decisions and the data are the former head of testing at NHS Test and Trace, also Chief Executive of Birmingham Women's and Children's Hospital, Sarah Jane Marsh, and the Deputy Chair of the Joint Committee on Vaccination and Immunisation, Professor Anthony Harnden. We'll speak to them in just a moment, but first, the government's overarching aim has been to reduce deaths and prevent the NHS from becoming overwhelmed. But from the problems around PPE to the pressures around supporting the economy and the success of the vaccine rollout, it's had mixed results.
Now, I know that there are plenty of things that people will say we got wrong. Of course, there must be time to learn the lessons, and we will. But I also know that some things went right, and emphatically right.
Imagine everything you love, but then set it on fire.
First lockdown was a nightmare because I had to beg on the streets.
If you've not got the adequate PPE, the system will fail at that point.
We know that there's a light there, we just can't quite see it yet.
It's the biggest day that we've had in terms of falls since 1987.
Who was expecting this to happen, you know?
For the first time in our history, the government is going to help to pay people's wages.
If you produce a ventilator, then we will buy it.
The distribution element has been a little bit tricky.
The Nightingale hospitals will rightly go down as landmarks in the history of the NHS.
We need everyone to treat PPE like the precious resource that it is.
Why we're having to struggle to get this equipment in place, it's appalling, really.
The only job I've really had since college, so I'm not really sure what we're all going to do.
I can't do another 2 weeks inside.
In Oxford, human clinical trials are beginning in a mission to develop a possible vaccine.
I have a simple message. Download the app.
We're getting told that every staff member in healthcare will be tested. It's a lie.
We don't even know how many NHS staff are off sick.
We have met our goal. 122,347 tests.
All of my gigs from last year got cancelled.
This is a government scheme designed to get people back eating out.
After £12 billion, why does the Prime Minister think that his track and trace system has gone so wrong?
This could be the end of the road for my business.
This care home is now full of NHS patients.
Teams working in tandem to maintain the barrier leading into the hot zone.
We learned a lot from that first wave. We learned some of the treatments that help.
The Chancellor has extended the furlough scheme.
We all rely on this so much, even more now.
If I lose my job, I'm not getting another one.
The UK is facing a significant recession.
We've stopped short of having total closure of the border.
The UK COVID-19 vaccine rollout has begun.
When those vaccines have finally freed us from this virus, we will make sure we learn the lessons.
Now, we'll get into the detail shortly, but first, I just want to ask all, I guess, the same question that we began with last night. What for you is the single moment or memory that stands out as significant over the last year? Jeremy Hunt, to you first.
Well, I think the saddest one was when the first doctor died. I think it was an organ transplant donor back in March. But the one that's really stuck in my mind has actually been the moment that Sir Tom Moore was knighted. That was just such a British occasion in extraordinary times. I don't think anyone who saw that will ever forget it.
Yeah, I think it was such an incredible moment for all of us, what Captain Sir Tom did. Victor Adebowale, to you next. What's the one memory that really stands out for you?
There are so many that stick with you, but I guess on an individual basis, it was the what happened to Belly Ginger, who was a ticket a frontline ticket officer at King's Cross, and someone abused her and coughed and spat at her, and she died of COVID at the age of 47. Her colleague got COVID and recovered, and for me, it just told us the story of the frontline workers, not just my colleagues in the NHS, but also those colleagues that are supporting NHS workers getting to work and just trying to do their jobs. I guess the other thing was when we had the stopping of elective surgery, because at that point we knew that the NHS was at real risk of being overwhelmed. And as we stand, we've got 4.6 million people on the waiting list, and that is something that we have written to the Prime Minister about, because any recovery has to take into account the sheer weight on NHS staff at this moment in time.
It's certainly something that we should get into later on the programme as well, a really important point. Let's go to Sarah Jane Marsh now. What's the one significant moment for you that sticks out from the last 12 months?
For me, Sophie, it was standing in front of the hospital I'm Chief Exec of, Birmingham Women's and Children's, and watching as one of our much-loved consultants, Vish Rasaya, was brought in front of the hospital with all the staff clapping as part of his final journey, because he was the first member of staff at Birmingham Women's and Children's who died of COVID. And then watching his beautiful wife and daughter get out the car and just come to me and say thank you for everything that you've done for Vish, when it was Vish that had done everything for us. That's a moment that no family should have to go through, no body that works in the NHS should have to go through. And it was just such a pivotal moment, and yeah, it'll stick with me forever, and we'll obviously miss Vish forever.
Thank you for sharing such a personal story. It does feel really important to bring it back to those individual stories as well when we're talking through the data and everything, and just remember it's about people primarily. Professor Harnden, what moment sticks out for you?
Well, I have two moments, Sophie, if I may. The first moment is on the 30th of December, when we approved the Oxford AstraZeneca vaccine and made the bold decision on JCVI to have a delayed second dose strategy so we could immunise millions of people. That was a really pivotal moment in our fight against coronavirus. My personal moment was on the 12th of March, 3 days after my 60th birthday, when I developed COVID and then suffered a number of complications, including having to go up and down to hospital on 4 occasions. So my personal experience of COVID has really lived with me and has reminded me right the way through this vaccination programme of my determination that we protect as many people as quickly as possible against this awful virus.
Sorry to hear about your illness. Are you feeling OK now?
Well, I've had a form of long COVID. I'm feeling, I would say, 85% better, but I'm still not fully recovered even 11 months later, which is a real salutary lesson for what COVID can do to people, having been previously completely fit and well. So yes, I'm much better, thank you very much. But I'd like to be so fit that I went back onto my mountain bike and was able to do everything I could do before I developed COVID. But it will come, I'm sure.
Hopefully not long at all. Thank you all for sharing such an important range of memories and moments. Thank you. Now, from the start, the mantra was clear: to protect the NHS. But of course, there were and still are many other issues to consider. And as our timeline makes vividly clear, the various different priorities often competed with each other. And some safety measures, notably the vaccine rollout, have been more successful than others, like the test and trace system or the PPE shortage at the start of the pandemic. Well, let's talk about PPE first, because on the 7th of February, the World Health Organization announces a severe global disruption in the supply of personal protective equipment and says priority should go to health workers, closely followed by those who are sick or caring for someone who is sick. And on the 25th of February, the UK government issues this guidance. It remains very unlikely that people receiving care in a care home or the community will become infected. People in care settings are not advised to wear face masks. Now, that changes 2.5 weeks later, when on the 13th of March, the government publishes new guidance saying that PPE should now be used for close personal contact, such as washing and bathing, personal hygiene, and contact with bodily fluids. on the 10th of April with stories of inadequate PPE mounting. Matt Hancock says there is a Herculean effort underway to get vital supplies to frontline workers. But it's not all bad, because on the 23rd of April, the first human trials of the coronavirus vaccine in Europe begin in Oxford, well ahead of many people's expectations, and it's confirmed that the UK will get the AstraZeneca vaccine first. Back to PPE. And on the 28th of April, we get new guidance saying that care home staff should use it regardless of whether residents in your care home have symptoms of COVID-19 or not. Now, remember, this is 2 months after the government said people living in care homes were not likely to become infected. Now, by now, it's clear from countries who've successfully contained the virus, contact tracing is key. And on the 5th of May, the first version of the NHS contact tracing app enters a trial phase on the Isle of Wight. But at the same time, the scale of the problem in the care sector is starting to become clear. On the day that the Office of National Statistics revealed over 40% of COVID deaths are occurring in care homes, a Sky News investigation exposes the depths of the crisis in care.
The social care system was in crisis long before coronavirus arrived, and social care providers say that it will now shine a light on some of the pressures that they've been facing in recent years. And long after the pandemic has died down, the government will be once again under pressure to reform this entire system.
Well, let's go back to test and trace. And on the 21st of May, Sage warns that the system will become overwhelmed if it's launched during a time of high prevalence of COVID-19. And on the same day, the NHS Confederation warns that time is running out to get it up and running. A week later, the testing of people with suspected coronavirus becomes part of the official NHS test and trace programme. But MPs are told it won't be fully operational until the end of June, and it quickly becomes overwhelmed. Now, on the 18th of June, Matt Hancock says the government is abandoning the development of its own contact tracing app, focusing instead on Apple and Google technology, despite previously saying it wasn't good enough. Good news, though, on the 20th of July, with the UK securing 30 million doses of the Pfizer-BioNTech vaccine, the first such agreement signed in the world. Now, despite not having a functioning test and trace system, the summer was characterised by initiatives to reopen the economy. Over the bank holiday weekend alone, 44.6 million meals would be claimed through the Eat Out to Help Out scheme. But a month later, and deaths are rising again. And it isn't until the 24th of September that the NHS contact tracing app finally launches in England and Wales. Now, let's fast forward to the 2nd of December and a major breakthrough as the UK becomes the first country in the world to approve the Pfizer-BioNTech vaccine. And Margaret Keenan becomes the first person to get the jab on the 8th of December as the rollout of vaccinations begins. But then, on the 14th, Matt Hancock announces that a new variant of the virus has been identified in the south of England, with over 1,000 cases detected so far. On the 30th of December, UK regulators approved the Oxford AstraZeneca vaccine for use. It's also the day that the Joint Committee of Vaccination and Immunisation increases the gap between the first and second doses of vaccines to try and increase uptake. And now it's a race against time. On the 22nd of January, with around 6 million people vaccinated already and deaths close to 100,000, new research from the government's virus experts revealed the so-called variant of concern is likely to lead to an increased risk of death. Now, let's bring in our panel at this point, shall we? Jeremy Hunt, to you first. Do you think that the success of the vaccine rollout will help perhaps people forget some of the failures of what's happened over the last year, particularly on PPE and test and trace?
Well, we need to remember everything that's happened because we've got to learn the lessons from it. And the biggest lesson of all is that in a pandemic, you have to act faster than the virus. And we were too slow to lock down. We were too slow to get PPE problems sorted out and to get the test and trace capacity up and running. But we've been one of the fastest in the world when it comes to vaccine approval and distribution. And that, I think, is our great hope, providing we can get this vaccine out to the majority of the population before we see any variants arrive in the UK that may potentially be immune to some of the vaccines. Then if we can get the case levels down quickly enough, we've got a chance of succeeding and really being proud of the fact that in this area, Britain has been the fastest and most successful country of its size anywhere in the world.
You say that we were too slow to lock down, but it seems to me that part of the reason we were too slow to lock down was because we were following the wrong plan, the pandemic plan for a flu epidemic, not something like coronavirus. I mean, you were the longest-serving Health Secretary. Don't you have to take some responsibility for NHS planning as well?
Yes, I do. And we planned extensively for pandemics. In fact, we were rated the second best prepared country in the world by Johns Hopkins University in the United States. But we now know that we were planning for a flu pandemic, and there was a groupthink, not just in the UK, but I think across Western Europe and North America, that pandemics are likely to be flu. We obviously know that's not the case now. But that groupthink, crucially, did not exist when it came to vaccines, where the original planning for the Oxford AstraZeneca vaccine started back in 2016 under Chris Whitty's leadership, because he used to work at the Department for International Development after the Ebola crisis, in which we started to fund the development of a vaccine for the MERS virus. And that proved very helpful in developing the Oxford AstraZeneca virus. So I think what we've learned is that we've got to be much more open-minded to the kind of virus that we might be subjected to, and being better at horizon scanning across the whole world and really thinking what the risks are is definitely going to be one of the most important lessons.
Well, let's talk about vaccines a bit further, shall we? We can bring in Professor Harnden at this point. The WHO, the World Health Organization, really backing the Oxford AstraZeneca jab today, but there have been concerns about how well it works against the South Africa variant. How worried should we be?
Well, I think we should be concerned but not worried. We do know that this was a very small study in South Africa which looked at very young people and showed that it wasn't so effective, the vaccine against mild disease. But all the evidence shows that this vaccine is highly protective against severe disease, hospitalization and death. And we do know that the predominant variant strain circulating in the UK at the moment, which is the Kent virus, is very sensitive against the vaccine and very sensitive against hospitalizations and deaths. We know that there are small pockets of the South African variant circulating in the UK, but we do believe that that virus is not quite as transmissible as the Kent variant, and therefore it is likely over the next few months that the Kent variant will stay the predominant strain. So the clear message really to people is to have confidence in the Oxford AstraZeneca vaccine and to take it up when offered, because it's likely, almost certainly, to provide excellent protection against severe illness.
You say that the Kent variant is likely to stay the dominant variant for the next few months, but could that change as more people get vaccinated? Could we see the South African variant becoming more prevalent?
Well, we do know that this virus is very agile and its raison d'etre is to transmit, and therefore it will be looking at all sorts of ways to try and transmit even amongst people that have been vaccinated and people that have already had the illness. And so this is why it's so important that we have a continual two-prong effort for this. Vaccinate as many people as possible, but have clear social distancing and other physical measures, distancing measures to prevent transmission. And if we can do both in tandem, get a large proportion of the population immunized and maintain social distancing, then we will get on top of this virus. But we will probably, because it mutates so frequently, we will probably have to live with it. But it will circulate and cause disease in a much more mild fashion. And it is my belief that we will end up having to have an annual coronavirus vaccine for the forthcoming years, probably tailored to the predominant variant strains which are circulating in the UK at the time. But the clear message really at the moment is for people to take up that vaccine when offered, because it is our major route out of this pandemic. And these vaccines are so effective. We are so fortunate to have such fabulous scientists that have been working so hard over the world to produce these vaccines. And it's quite miraculous, really, that they are so effective right the way across the board. That's the messenger RNA vaccines, the viral vector vaccines, and the protein subunits and wholesale vaccines. So lots of different types of vaccines, lots of opportunities to tweak and edit them. But let's just get vaccinated as quickly as possible, and let's go very slowly in terms of how we release the lockdown.
Lord Adeboale, Britain's black and ethnic minority communities have been more likely to die from COVID-19, but also more likely to not take up the vaccine. How concerned should we be about this?
Well, I think the vaccine has been, the rollout of the vaccine has been an absolute triumph of science, strategy and delivery by NHS staff. It really is truly remarkable. It looks like we're going to hit the target this week, and we're touching about 13 million. But we are in danger of hitting the target and missing the point. And the point is that we have to vaccinate everybody, and we can't leave anyone behind. And we should be very concerned about the vaccine hesitancy, not just in black and minority ethnic communities, but in other communities as well. And of course, we need to ensure that the homeless and those that are vulnerable for other reasons get access to the vaccine. But I'm very concerned about the disproportionality. The first 10 people to die in the NHS were all people of colour, and we are seeing disproportionate take-up of the vaccine and vaccine hesitancy at worrying levels in the black and minority ethnic community, and that should concern us all.
It does feel like one of the lessons from the first wave was how disproportionately more people from black and minority ethnic communities were affected. Do you think we learnt that lesson later on or not?
I think that we are learning that lesson, and it's all too late. In a sense, it is obvious. If you look at the people who are most likely to have worse experience of many NHS services, worse outcomes, they are members of our black and minority ethnic communities. So it does follow that in a pandemic, they will also suffer because they tend to be in the poorest areas doing the frontline jobs that are least paid. So if you address the issue of inequality and inequity, then by definition, you will also address people from black and minority ethnic communities. And that's a lesson we have painfully learned during this pandemic, and we can't really afford to learn again.
Sarah J. Marsh, test and trace not only failed to prevent lockdown once, but twice. What went wrong, and should we be any more hopeful that it's going to actually work in the future?
Yes, I think the test and trace journey has got many successes in it and many things that clearly needed to be done better. I think one of the challenges that we faced from the start in test and trace is the time that we had to go live with it. Many of us that were in the test and trace leadership team actually came into post in mid-May, and we had to get the service up and running in June. We knew that. So, there was literally days to create something of the scale and complexity that was needed to keep everybody safe in the country, or as part of the response to keep everybody safe. And I think that lots of things about test and trace have been a success. We didn't have the testing capacity when the pandemic first started to be able to test more than a handful of people. We got to the 3,000 tests, but we knew that we needed many more. We went on a massive journey, not only to increase the testing capacity that we had, but also the way that people could access the testing itself, so that you could go to a local community centre, or, you could access it via a GP or through your local director of public health. We also worked really hard to think about how we could improve the turnaround times for testing, so we could get results back really quickly, and that we could get those results into the contact tracing system. But this was all happening in a dynamic way. It wasn't that we were having the time to work this out. The numbers all the time and the challenges that we faced were great. But I do think that we were learning as we went. I mean, one of the things that, really we put focus on in June, July time was how we could tip the system from being very nationally focused to being much more about working locally as well, making sure that we got that connectivity into local communities for some of the reasons that Victor's just said. We needed to work alongside people who understood where the virus was most likely to be, where we might have asymptomatic people, where transmission risk was higher. So lots of work went into our relationship with local councils. And I know that that was slower than some people would have liked, but I do think that we did start to move that forwards. So I don't think this test and trace is a story of something that was, everything was perfect or everything was a disaster. I think there are lots of things about it that were actually done really well, and now it is starting to work. You can see the impact, that it's making. I think that in time, we will have a system that everybody can be proud of.
When I talk to people about test and trace, quite often they talk about the testing aspect, like ramping up testing very quickly, and not so much about the other half of the name, the tracing aspect. And it does feel that, people weren't giving enough contacts to you, and those contacts weren't necessarily being followed up in a timely sense, and then people weren't even self-isolating if they were told to as well. I mean, for a system where we spent more on test and trace than the budget for the fire and the police, is that really good enough?
No, I agree that the testing system was more developed. The testing, we were working really hard on it from January, February time, whereas the contact tracing system was stood up much more quickly in May. And it took, as I've just described, it took through the summer really to get the right connectivity between the national system and the local system. It's an end-to-end process, as many people have said. There's no point in just doing the testing and getting a quick result if we don't act on it. So I think that was definitely, a big area of focus for everybody that worked in test and trace. And there were some real advocates throughout, that were really talking up and using every opportunity to think about what was stopping people, particularly from isolating. We were hearing many stories back about people being scared of testing positive in case it meant that they couldn't go out to work, for example. Where were they going to get money from to put food on the table? And there was a big advocacy sort of approach from people in NHS Test and Trace to say, how do we address some of these issues and how do we support people to isolate? But again, I think you can see as the data's kind of evolved over the last few months that actually it is now more of an end-to-end system, and that we are identifying more contacts kind of collectively. That's both through the national system and through the local contact tracing systems as well. The two things are working hand in hand, and we are starting to see some improvements there. But I do think, sort of going back to lessons learned, we were working hard on the testing system from February. The contact tracing element didn't start in earnest really until May, and I think some of the issues that we saw were because some of that disparity and when the different elements of the system really got underway.
OK, interesting, thank you. Now, we've become used to seeing graphs like this showing how the virus has ebbed and flowed since it first emerged. But all of those statistics are, of course, people, individuals, families, lives turned upside down. And one of them is Ali Sakaloju, who is believed to be Britain's longest suffering COVID patient. He and his daughter Jay join us now. Thank you so much for being on the programme. How do you think you contracted COVID-19?
Well, that's everyone keeps asking me that. I can't really say for sure where I got it from. It's one of those things that's just happened. I can't. It could be from a shop. It could be from anywhere, really. So I can't tell you specifically where I actually caught it from.
And how?
But it was around.
And how? What? Sorry, you were saying.
Yeah, it was around end of March that I actually caught it. So I got a slight cough and my temperature was rising. So I found out my daughter, Shani's, and I actually told her, and she said to me to ring 111. That's when I rang 111 and they told me to stay at home, self-isolate, and if it gets any worse, I should bring them back. And after 24 hours, 30 hours, I started to get, breathing problems. I was coughing much more. And that's when my daughter she phoned 999 for the ambulance to come and get me. So that when they did arrive, they put me on these machines and did tests on my oxygen levels, and they were really low, and they sort of rushed me to the hospital. And then that's when they were doing these tests and putting a mask on and other machines on me and to do other tests. And that's when I had a heart attack. So then they rushed me to King's College Hospital. By then I was unconscious. I can't remember actually getting to King's College Hospital. But this is when they told me afterwards that I had a heart attack, and then they'd done a surgery on me. They put a stealth in, you know, into my heart, and then my lung collapsed while they were doing the surgery. So then there was other complications. And then when I actually did wake up, you know, which I thought was the next day, it was 10 weeks later. You know, my daughters were telling me, and my girlfriend, they were saying to me, you know, on WhatsApp, FaceTime or whatever, that I've been asleep for 10 weeks. You know, and I couldn't believe it. And in the meantime, I had liver failure, kidney failure, lung failure. I had sepsis in my lungs. You know, I had gangrene. I was on machines. I was on a ventilator. I was still having problems with breathing, and I was putting up loads of phlegm, and I was in a bad way. And you know, when my kids were telling me all this, I just couldn't believe it. You know, I just thought it was the next day, but it was 10 weeks later, and I was still in a bad way. And you know, gradually I was getting better, but it took a while, you know.
What an incredible fight you really had. How are you feeling now?
I'm feeling a lot better, you know. The fight was that, thankfully for the NHS, the support of my girlfriend and the support of my kids, you know, they were important, and they helped me through that vital time, especially the NHS, the physios, the doctors, the nurses, you know, my kids, my girlfriend, all their support. You know, I'm feeling a lot better than I was. I'm still about 50, 60%. You know, I've still got a long way to go, because when I woke up, I actually couldn't move a muscle. So you can imagine, you know, I'm laying there, I can't move. I just about can breathe, you know, I'm on a machine, you know, tubes coming out of my throat. So, you know, I was pretty bad, you know, and I'm getting better. Every day is a new day. So every day I am getting better, yeah.
Well, it's lovely to see you both smiling and talking about getting better, and we wish you the very, very best in your road to recovery. What an incredible story. Thank you both very much. Lord Adebowale, I mean, what a story. It just really demonstrates the pressures that the NHS has been under dealing with these very complex cases and so many individual stories.
This has changed out. Well, first of all, I hope that you continue to get better. That is a hell of a fight that you've been through, and it tells the story of how the NHS has worked together as a team to not just deal with the acute phase, but also the recovery. And you know, we are now talking about a new service that we need to provide in the NHS. My colleagues are talking about long COVID cases now over 100,000, and it's not just the physical issues; it's also the mental health issues. And when I talk to my colleagues in the mental health networks, what they're telling me is that we're looking at 10 million additional cases as a direct result of COVID. So this has changed the shape of the kinds of services that the NHS will need to deliver going forward. And we have to build that into any kind of credible recovery.
Mr Hunt, there are reports the government is looking at restructuring the NHS. Do you think we do need to look at how we structure and fund the NHS going forward in light of what's happened?
Well, I think we need to make this a really big moment in the NHS's history, because it's just been through the biggest challenge. And frankly, it's come out with flying colours. I mean, Ali's story is amazing. Every single patient who's needed a ventilator, who's needed an intensive care bed, has got one. And, you know, as a country, we haven't got everything right in our pandemic handling, but I think the NHS can be very proud of what it's done. But NHS staff are absolutely exhausted, because they've got the double whammy of 25,000 odd COVID patients and the backlog of all the cancer surgery, the hips, the knees and so on that have to be done. So I think the one thing that we could really do for NHS staff this year is to put in place a long-term plan to sort out the workforce shortages. I don't think we've ever really been good at training enough doctors and nurses for the future. I increased training places by 25%. In my time, it was a huge increase, but now I'm not sure that even that was enough. And I think what NHS staff would like to know, they know it takes 7 years to train a doctor, 3 years to train a nurse. You can't solve these problems overnight, but they'd like to know that there was a proper plan in place so that over time we can start to deal with some of these gaps in the workforce that create so much stress.
Well, let's talk a bit more about hospitals, shall we? Because hospitals really are the front line in the war against coronavirus. Daily battles in intensive care, like the one we just heard from, are the difference between life and death. And that statistic that we just heard from Jeremy Hunt, because over the last year, despite all of these deaths, not a single coronavirus patient was denied a hospital bed or a ventilator. But that's come at a huge cost, both financially and, as we've been discussing, in care homes as well. Now, on the 17th of March, in anticipation of an influx of COVID cases, NHS England sends this letter to hospital trusts saying that patients who are medically fit to leave should be sent home, or crucially, to a care home. Now, on the 3rd of April, the country's first Nightingale Hospital opens in London to provide extra capacity and to treat COVID-19 patients. The 12th of April is the peak of the first wave. Now, at this point, there are 21,686 patients with COVID-19 in hospital, and there are 3,301 on mechanical ventilators. It's also the day that Boris Johnson is discharged from hospital. And what's happening in hospitals is now a real worry. When SAGE meets 2 days later, they warn that there is significant transmission in hospitals. The 20th of April is the start of a week where the pandemic's impact on non-COVID treatment begins to show. Urgent cancer referrals are down 62%. 6,000 fewer people are able to receive chemotherapy since the first lockdown began. Now, we're into summer now, and with numbers starting to fall, Matt Hancock declares that we are winning the battle against coronavirus. Some lockdown measures are eased, schools start to reopen. Just over 6 weeks later, on the 17th of July, the Prime Minister announces an additional £3 billion of funding to the NHS in England to get ready for winter. On the 17th of September, SAGE discusses scenarios where hospital admissions double every 7 to 9 days. They warn that this does have the potential to overwhelm the NHS. And by the 8th of October, the group says that hospital admissions in England are now exceeding their reasonable worst-case scenario planning. And NPIs, that's non-pharmaceutical interventions like lockdowns, are needed. Now, let's go to the 17th of December and just look now how those hospital numbers have really jumped. SAGE discusses those. They say this: the full effect of the festive period will not be apparent until January. Even a short period of epidemic growth could lead to the number of new hospital admissions in early January 2021 exceeding the peak of the first wave. And on Boxing Day, that's exactly what happens. The number of COVID-19 patients in UK hospitals is now at its highest point ever, and it's still rising. By New Year's Eve, it's estimated that 1 in 8 people in England had COVID in December. And Sky News reveals that the intensive care units in 3 London hospitals have now reached full capacity. Now, this is the first SAGE meeting of 2021, the 7th of January. Let's have a look at the minutes. Mortality reductions from vaccination will not begin to be seen before the end of January. At the very earliest, more likely it will be later in February. The pressures on the NHS will take longer to reverse. 24 hours later, Sadiq Khan declares a major incident in London. If we don't take immediate action now, our NHS could be overwhelmed and more people will die, he says. 3 days later, Boris Johnson warns of a perilous moment during a visit to Bristol. In Southend Hospital, this letter is circulated to staff about the use of oxygen. It says, we've reached a critical situation with oxygen supply. It's imperative we use oxygen safely and efficiently. Now, the next day, Sky News reveals that during the pandemic, excess deaths rose by more than in any year since 1940. And this, the 18th of January, this is the peak of the winter wave of patients in hospital with COVID-19. Over 14,000 more people are seriously unwell now than during the first wave. 6 days later, the number of patients on ventilators reaches its highest level ever, as Sky's home editor, Jason Farrell, reveals the pressure on exhausted medics who are battling to keep COVID-19 patients alive at London's Royal Free Hospital.
I feel like I want to cry in many moments. I mean, I can't do my job properly.
What's been the toughest thing for you?
Well, basically, I mean, lots of people are passing away, and you have to keep doing your job when you have a gentleman or a lady that is passed away and is lying next to you, and basically we just need to keep going and wait for somebody else to come and take care of that, and it's horrible.
Well, we can speak now to someone who will only recognise that too well. Dr Charlotte Summers, an intensive care consultant who sits on the council of the Intensive Care Society. Thank you so much for being with us. What has the last year been like?
I think it's fair to say that for me and everybody who works in intensive care, it's been the most challenging year that any of us can remember. We have, in many cases, not returned to what we would recognise as being pre-pandemic intensive care at any point. There are many ICUs that have never actually got back to having their pre-pandemic bed footprint, because when the COVID wave 1 went away, all of the patients that had non-coronavirus related illnesses increased. So for the whole of the summer, we were doing more work than we would most summers relating to things that didn't get dealt with, or the things that worsened during wave 1 of the pandemic. And just when we've recovered from that, we've had a second wave which has been even worse than the first. So it's been a really challenging year.
Do you think the lessons were learned from the first wave of the virus in preparing for what we've seen this winter?
I think in intensive care, actually, we learnt a huge amount over the last year about caring for patients with this virus and for being prepared for future surges. So I think actually a lot of knowledge sharing and lessons were learnt. Do I think nationally that we got everything right? No, of course not. But there have been some things that have gone really quite well too.
And how's it been? One of the things I always think of, how difficult it must be showing the humanity that you would normally give to people in hospital or in intensive care, being able to see their loved ones, being able to have that face-to-face contact. How hard has that been, not to be able to do everything you would normally like?
That has been probably one of the most extraordinarily hard bits of the pandemic, because our patients' families would normally be at the bedside. So normally we would be having those conversations with them ourselves face to face and explaining what was going on, and they could see what was happening, and we would be able to, when bad news needed breaking, do it in person. Now we've been having to do that via things like this, so via Zoom or Skype or telephone, and that is extraordinarily hard for the loved ones of our patients, for our patients themselves, but also for staff. I think all of us have found it one of the most challenging aspects of the pandemic for us.
Yeah, I can imagine that must be unbelievably difficult for NHS staff already under so much pressure as well. Lots of people as well talk about a typical COVID-19 patient, but are you seeing a real range of people in your intensive care wards?
Yes, I think a lot of people have got an image of someone who's possibly older and has coexisting health issues. I think it's important for us to remember that half of people who've been admitted to intensive care units are under the age of 60 throughout this pandemic. So half my patients are working age people who are of an age that they're very much like the staff in intensive care. So, you know, people my age, people younger than my age, people the same age as my partner and other people's husbands and loved ones. I think it's important to remember that there is no typical coronavirus patient. There is a spectrum from people who are very young to people who are more elderly, both in intensive care and where 90% of people with coronavirus are looked after in hospitals, which is outside the intensive care unit.
Thank you so much for sharing a bit with us about what it's been like, you know, working in these intensive care units over the last 12 months. We really thank you for your work as well. Thank you. I just want to pick up on something that was just said there about non-COVID illnesses. Sarah Jane Marsh, are you worried about how people without COVID-19 has suffered during the last 12 months? First wave, for example, urgent cancer referrals down 62%. Are we looking at a healthcare time bomb here?
Yeah, well, I think our NHS staff have done an absolutely amazing job on looking after patients with COVID and have done our absolute best to keep other essential services going. I mean, in my area, maternity, you know, nobody told the babies about the pandemic and they've kept coming. So in services like maternity and our mental health services, we have kept going and, you know, are continuing to deliver really fantastic services in difficult circumstances, but there are some things that we simply can't do. As you've said, we know there are people sort of waiting urgent cancer treatment. There are people living in pain. We know we won't be able to give their operations in a timely way. And I think this is a huge source of distress to many people who work in the NHS. We're there because we want to be able to provide that high quality service to everybody who needs us. It's one of the founding principles of the NHS. And not to be able to do that, it is a big worry. And at the moment, we're just planning how we do that. We, fingers crossed, appear to be, coming down out now of the current peak, which means that we can start to think about how we recover some of our services. But we have to accept that alongside restoring our services, we have to restore our people as well. You can't ask people to work in these really difficult conditions, wearing all of this PPE, long shifts, working outside of their areas, outside of their roles, sometimes outside of their organisation, to just get back to normal next Monday. And I think this balance between sort of recovering our people and being able to recover our services is probably for me and my colleagues, the chief executive community, probably, one of the biggest challenges that we'll face in our careers.
Lord Adebowale, do you think the pandemic has exposed issues with the structure of the NHS? Would you welcome, for example, reported reforms giving the Health Secretary more control?
Well, look, the NHS didn't go into the pandemic in an excellent state. We were already 100,000 down in terms of staff vacancies. We're now about 87,000 down and about 38,000 nurses short. There were already some issues around, investment. So we went into the pandemic with some issues. What the NHS has achieved is truly remarkable. Sarah and her colleagues have pulled this country through one of the worst crises in living memory and continue to do so. And we have to respect that. And, I think that we owe it to them to think carefully about how we support them through the next phase, which is about recovery. And I absolutely agree, as do many of my members across the NHS, not just those in acute hospitals, but in mental health trust, community, and primary care. We owe it to them to really plan the run into a different kind of NHS. And that's one in which we work together. That's one in which health and social care are integrated. It's one in which we have population health structures delivered. And you know what? I'm not really going to get into a debate about, whether the Secretary of State has more or less control or not. I sat on the board of NHS England for 6 years. I think it's perfectly reasonable that the Secretary of State should have line of sight of how we spend well over £160 billion. The question is, the Secretary of State and politicians need to give the appropriate authority to those people who understand their populations, understand how population health can work and should work, give them the authority to plan carefully and deliver the services that those populations need. If we can do that, then we can turn this around and we can learn from the pandemic in a magnificent way, because the wish to do it, the wish to deliver healthcare has not been diminished by the pandemic. The leadership and the delivery in the NHS is truly remarkable, and they deserve a leadership at the top to support them.
I want to talk about care homes. Almost a third of all COVID deaths came from care home residents, and right now we're seeing deaths in care homes rising to levels that we haven't seen since the first peak. But people can still be discharged from care homes without a negative test. Mr. Hunt, what happened to the protective ring that was supposed to be thrown around care homes?
Well, we've clearly got to learn lessons. I think we have learned lots of lessons about that. In Germany, they had a rule that if you couldn't quarantine someone in a care home with full protection of the other staff and other residents, then care homes weren't allowed to accept people from hospitals. And that was one of the things we didn't do last year. Now, when people are discharged into care homes, enormous precautions are taken, and we do need to free up hospital beds as well. But I would just echo something that Lord Adebowale said. When we are planning the future of the NHS, we also need to do the same for the social care system. Because I think one of the things that has become clear to the whole country, if anyone wasn't aware before, is what an amazing job care workers do often at very low pay rates. They've been under enormous pressure working in care homes, but also out in the community, going around visiting vulnerable people. And I think we have a 10-year plan for the NHS, which I think has been welcomed by the NHS. I think it's time we had a 10-year plan for the social care system and for the social care workforce to give them that long-term confidence that we're addressing some of the very entrenched problems that have existed there for some time.
But if they are to be valued, they weren't valued, particularly at the beginning of the pandemic. They weren't even given the right PPE, were they, when hospitals were prioritised?
Well, in Hong Kong, they learned after the SARS epidemic that all care homes were, first of all, very vulnerable places, and they required care homes to have 3 months' supply of PPE. And I think that's the kind of lesson we will definitely learn for the future. So yes, there's a lot that we have to learn, but I think we also have to recognise that our social care system was in a very distressed state before, and successive governments, including the one that I was part of, were keen to push forward reforms. But now, if we don't do it this time, after we've seen just how heroic the work has been in the social care sector, we're never going to do it. So I think this is really the moment when we have to grasp the nettle on social care reform.
Professor Harnden, how concerned are you about the take-up of vaccines among care home workers?
I'm concerned. I think it's a real live issue. In fact, we do know that care home residents have taken up the vaccines in very large numbers, but there are a proportion of care home staff which still haven't. And I think the message still needs to come across loud and clear to them that they're not only protecting themselves, but particularly with the Oxford AstraZeneca, as we know, affects transmission, that they will affect, they will protect their elderly residents who they really care for deeply in potentially contracting the virus from them. So it's really important that we continue to really press home that message. And I think the message is starting to get through, but we still got a long way to go. Can I just go back also to the problems of the health service? I do think that the way that the NHS has tackled this crisis has been nothing short of miraculous. But I do think going forward, we really do need to look after our workforce better. I think that, we not only need to increase numbers of doctors and nurses, but we need to look after them and care for them and make their working conditions really good. We also need to, one thing that hasn't come out is we also need to embrace technology more. I do believe, certainly in primary care and throughout the health service, that actually technologies have probably advanced about 10 years during this pandemic, and we're all getting used to communicating through technological means now. And I think we could really embrace this within the health service and make things a lot more efficient. And finally, I'd like to say that I do strongly believe that we ought to integrate, as Jeremy Hunt's just said, social care, health care, and public health in a much better way. And we do need to think very clearly how we're going to do this. Could be done very easily through primary care networks, but it needs to be thought about very carefully, because it's the pandemic has brought this really into sharp focus that actually the elderly people that have been most affected by this pandemic also require an awful lot of social care and integration with their health care. And so we really, really need to look at this very strongly as a country and work out how we're going to shape our NHS so we look after this demographic population. Just going back, really important point about the workforce. We need to look after the workforce. They've been a beacon of light during this pandemic, and we need to make sure that they're valued.
Talking about looking after people, who should be prioritised next for the vaccine? Should we be looking at teachers, as some have called for?
Well, we're quite clear on JCVI that we've outlined 9 priority groups which go down to the age of 50. Now, of course,
after that, who do you think should be prioritised?
Well, I think we need to look at the data, and we need to see, as your contributor from intensive care said, there are still a number of younger people which are getting very, very sick from this virus. So we need to look very carefully what the risk factors are for severe illness. Then we need to look at other factors like transmission, who is likely to be transmitting to others. And then we need to look at other factors like key workers, particularly with those with occupational health exposure risk. So there are a number of factors to look at in this phase 2, but JCVI are clear that disease and burden of disease still needs to be really important in the prioritisation list. So we will be looking at all these factors in combination, and we'll be coming up with a very clear decision about how we should prioritise in the next phase of the programme. But we do have to remember that all people will be offered a vaccine, and that will be in a relatively short period of time, given the pace that we're rolling out this vaccination programme. So maybe a little bit of patience is required, but we will get to everybody, every adult in this country before too long.
When do you think before too long is? Just very briefly, I'm running out of time.
Well, JCVI don't set targets, but I do believe Dominic will be on record for saying September, but it may be sooner than that.
OK, thank you very much for all our panellists for this evening's programme. Jeremy Hunt, Lord Adebowale, Sarah J. Marsh, Professor Harnden, thank you very much for your contributions. Thank you. Well, that is it for this evening, but tomorrow the British public gets its say. We're going to be joined by a senior government minister who is going to be facing the questions of a virtual studio audience on everything that we've heard this week and more. So do please join us tomorrow night for the final part of COVID crisis, Learning the Lessons. That's at 8 o'clock here on Sky News. Thank you for watching and good night.